Hello and welcome to 4D 2.0. This is episode number 26, where doctors are going to be speaking to doctors about very, very important topics with regard to diabetes and how it affects all of us. Today we have Dr. Manjari, and she is an assistant professor from KM Hospital, Mumbai. She has her MBBS from Grant Medical College and her DM endocrinology from Seth GS Medical College. A professor has published a lot in the field of diabetes and endocrinology. She's been also won many presentations and awards in various national conferences and international conferences. She's the right person for us to talk about CV disease and diabetes. As we all know, diabetes and CV disease is a intertwine of multiple complications. Over to you, madam, to take it forward.
So first, we will have a short presentation on what is the pathophysiology of diabetes and cardiovascular disease. And as it is rightly said that they are indeed partners in crime, and there is no question of a question mark here. So to begin with, as we know that the prevalence of diabetes is increasing as the days go by, and in India, every 1 in 11 adults is living with diabetes, and almost half of them are undiagnosed. So India has now become the second highest country in the world with individuals living with diabetes. So definitely it is a very high disease burden, and that is why we really need to take care of these, and not just the glycemic control, but management of diabetes goes beyond that, and it is extended to cardiovascular risk factors, renal risk factors, the microangiopathic complications, so on and so forth. So, according to the International Diabetes Federation, the incidence of coronary artery disease among patients with diabetes is to the tune of 2.5%. And more than 65% of patients with diabetes die due to a cardiovascular disease, most of which is attributable to coronary artery disease. So, even the mortality after a coronary event is higher among Asian Indian patients to the tune of 40% as compared to the other ethnicities. So this was a diabetes and cardiovascular disease study. In this is called the Framingham Heart Study, and as is seen that the single risk factors like BMIs more than 27, smoking, total cholesterol, diabetes, and hypertension individually are almost equivalent in their contribution to the heart disease. However, when you have multiple risk factors, the risk goes on increasing exponentially, and that is why it is very important to take care of these risk factors before you develop this cardiovascular disease. So the incidence and the relative risk of CVD, cardiac failure, intermittent claudication, and stroke is increasing. And if you can see from these graphs, it is in fact a little more than more in women as compared to the men in the ages of 35 to 64 years. Now, what is the pathophysiology? So diabetes has a multiple complications which are ongoing. There is a good amount of inflammation which is going on. This low lying inflammation and the insulin resistance leads to increase in the cytokines, tumor necrosis factors which cause dyslipidemia, increased free fatty acids. There is reduced uptake of this glucose in the muscles, which in turn again increases the hypertriglyceridemia, the LDL cholesterol, and the diabetes. Specifically, there is the small, dense, low density lipoproteins which contribute to the plaque formation, the thrombosis, the advanced glycation end products. All these together increase the endothelial damage and endothelial toxicity, and therefore increase the risk for cardiovascular disease, particularly in patients with diabetes. So yes, so as I said, there are multiple mechanisms which are involved in development of cardiovascular disease in diabetics, and this is also because of certain epigenetic changes and intracellular metabolic changes which lead to oxidative stress, the low grade inflammation which is continuously ongoing in these patients, which lead to ultimately endothelial dysfunction and plaque formation, and so on with cardiovascular disease. So yes, Cardiovascular disease can be prevented or delayed by controlling the blood glucose, the blood pressure, the cholesterol, and intensive lifestyle modification like eating healthy, increasing your physical activity, and stop smoking. So, what is primary prevention? It involves preventing the and delaying the new onset of cardiovascular disease in patients with type 2 diabetes. Whereas secondary prevention is a patient who has established cardiovascular disease. You treat the risk factors in these patients so that the patient doesn't develop an acute coronary event subsequently in the future. So, what strategies can you utilize? So, early initiation of combination therapy to achieve glycemic targets or goals. So, as we have historically learned from the DCCT, which was basically in type 1, and the UKPDS trial in type 2, wherein early and intensive glucose control prevents development of microvascular complications and in turn also mitigates the development of macrovascular complications, and therefore it is very important. And there are certain novel medications which are now in our armamentarium which will help us control this and prevent CVD beyond glycemic control, and those are SGLT2 inhibitors, GLP-1 analogs, and DPP-4 inhibitors. So, what does a combination of SGLT2 inhibitor and DPP-4 do? So, combination, in fact, SGLT2 causes glycosuria and reduces the glucotoxicity. It also reduces the weight and the systolic blood pressure, and it has indirect pancreatic effects. Whereas DPP-4 is weight neutral, and it increases the insulin secretion, and therefore these two act in conjunction, and they are safe. They have lower risk of hypoglycemias, they reduce the pill burden, and then therefore they are cost effective also. So the cardiovascular benefits of SGLT2 inhibitors were seen by the DECLARE TIMI, which showed that dapagliflozin was non-inferior to placebo with respect to the primary outcome, which was 4-point MACE, and significantly lower cardiovascular death or hospitalization due to heart failure. So definitely SGLT2 inhibitors have a good cardiovascular benefit. This was the end of my presentation. Thank you.
Wonderful presentation, Dr. Manjari, and
Thank
I
you.
think you highlighted all the important points with regard to how the pathophysiology of what we are seeing with cardiovascular disease.
Yeah,
I'll start off sticking to the topic and then
sure.
slightly deviate from the topic little bit. So just few questions. I think when we are looking at heart disease, I think what I want to ask you is when we are seeing a patient for the first time, and we're taking the history, we're taking the family
Yeah.
history, we're looking at all these aspects. So now, how um, quite often we do see that yes, they have all these risk factors, and we are also starting them on the right medication. So how often do you think, as doctors, this step is very very key, starting with the right combination of medicines, making the right plan for the patient? So how do you think this step right in the beginning, how important is it for us to reinforce this to the other doctors who are listening in, madam?
Yeah, so definitely this is a very important step because, as I mentioned, that management of diabetes is beyond just glycemic control, and you have to look at the overall patient profile, and therefore you have to target these macrovascular and microvascular complications. So you have to plan a treatments as such that you are preventing the cardiovascular disease, you want to prevent the progression of nephropathy, and you want to take care of all the risk factors, and that is why these combination medicines come into play. And of course, when you are offering a combination like an SGLT2 and a DPP4 inhibitor, so SGLT2 inhibitors are known to prevent the progression of nephropathy and also reduce the heart failure percentage. So patients who are at high risk of these, definitely you should offer them these combinations as first line, of course. And also taking the patient profile into consideration, and giving combination also improves the compliance of these patients. So overall the benefit to the patient is good, and therefore we should always plan a holistic thing for the patient and not just glycemic control, which is very important in today's time, as the incidence of cardiovascular disease and nephropathy and deaths due to diabetes are on the rise.
Yeah, definitely, madam. I think it's, as you said, we have to reinforce this, we have to start correctly. And when we are managing our cases, we have to take everything into account. Now let's now put another twist to the, in the management. Now we have DPP4, we have GLP1. Now this is a newly diagnosed case, and with the DPP4, GLP1, and probably SGLT2. Now these three would be one of our starting points in most of our early case diabetes which we are using. And if you look at SGLT2 and GLP1, there are situations where we can't use these medications. So now how would you handle uh, either or if they're not tolerating GLP1, they're not tolerating an SGLT2. Now where do we stand? Now I want to offer that cardiac protection along with the glycemic control. So what would your practical advice be for our patients?
Yeah, definitely it then becomes very challenging, but it is very rare for patients to not tolerate both of them. I agree that if you want to put the patient on SGLT2 and the patient has history of pyelonephritis or SGLT2, you automatically that goes out of the box, and you cannot offer SGLT2 inhibitors to them. But definitely GLP1 RAs uh, can be offered to them. And tolerability, starting with a smaller dose, it usually is well tolerated in patients, and then gradually escalate that, so it works well in them. So I would say that either one of them you should definitely offer the patients, depending on what is the patient profile, the cost of the medications, and of course the patient profile and the risk factors which the patient has. Accordingly you can give them. So either of these definitely, but yes, glycemic control also is very important, and that remains the bottom line. So if either of these cannot be given, then the conventional medications like the metformin definitely needs to be offered to them. And over and above that, whatever else you can give to control glycemically. And of course, lifestyle is very important, because that is what is going to mitigate the risk factors also. If the patient loses weight, the insulin resistance is going to come down. Definitely that is going to change the whole pathophysiology of this cardiovascular disease. So that has to be underlined as a bottom line, that lifestyle modification, exercise and diet is very, very, very important when you are managing a patient with diabetes.
Yeah, you're right. I think, as you said, reducing the dose. If it's a GLP-1, they're not
Yeah,
tolerating, then it makes a difference. I think even with an SGLT2 as well, most of the time when we are starting, glycemic control is already little poor. So that's why they get symptomatic. And I think we should not be too scared as well. If there is a
yeah,
mild infection, treat the
correct.
infection and approach the case as these challenges come. And always, if we see the need, being there and the risks are not too high, we can definitely reattempt also.
Yeah,
So as you
definitely.
rightly I mentioned,
So yeah, I would just like to add one thing here, that definitely there are patients who come back with SGLT2 inhibitors who come back to you and say that they are having certain genital complaints of itching or burning, etc. So if you counsel them beforehand that this is an expected complication, and to maintain adequate genital hygiene beforehand, so that also works in quite a few patients. That they don't develop any of these issues if you have already adequately counseled the patient regarding these side effects, so it works well in them.
works well.
And
And
as you
I think,
said, that we can stop them and again reattempt to introduce them if they have not had a severe urinary tract
yes, yes,
infection or pyelonephritis for that matter.
exactly,
That acute pyelonephritis becomes an absolute contraindication, but
definitely.
minor urinary tract infection, it can definitely be reattempted. Yes.
So, as you mentioned, lifestyle. I think, I think now that would be not only a challenge for us in day-to-day practice for us to, even though we're counseling, we're reinforcing all the points, but in the end, they don't take it that seriously. And they'll say, no, no, this time I'm going to lose weight, or no, this is mango season, or there was this, this wedding or this function. So, how have you, especially in somebody who is at very high risk, and already dealing with probably obesity or obstructive sleep apnea, and they are dealing with the challenge of managing their diet. So how have you found it, in your practice? How have you overcome this challenge in tough cases, and what tips do you think you can have to share with us today, so that that we can easily reinforce a lifestyle in our diabetic population at high risk
So
CVD.
that definitely is a very very big challenge, because to accept the fact that in the first place they are eating a lot. First of all, they are always in denial that no, we don't consume so many anything, we are always having all the healthy food, and it is very difficult for them to accept the fact that they're actually having unhealthy food. So you have to point it out to them that these things which you are having, like processed food items, be it biscuits or anything, are actually unhealthy, and that is why you have to tell them that this is what is increasing their blood sugar. So you can actually sometimes offer them CGMS just for their purpose, not for our monitoring purpose, and ask them to see that if they eat a particular food item, their sugar is spiking so much. So that is also a point where they get motivated. Yeah, definitely, if I'm doing this, if I'm walking 15 minutes after having a meal, my sugar is coming down, and that is how I can effectively control it. So CGMS is one of the tools which you can utilize for the patient purpose, not for our monitoring or anything of that sort, but particularly for the patient motivation, it can be utilized. And the other thing is, if the patients have some major life event coming up, they have to attend some wedding, it's their own wedding or something like that, that acts as a big motivation for them to lose weight. But other than that, yes, if they have developed certain complications, then that is a life changer for them, and they accept this lifestyle modification. But otherwise, it becomes a challenge for us to convince them to try and lose weight. So it depends from patient to patient, it's sometimes just beyond control to motivate them. But this CGM is one of the tools which I have utilized in
Yeah.
quite a few patients, and it works in them.
Definitely, they're seeing the spike, and they were never monitoring at all. Suddenly, they're like, "Oh my God! Okay, Subha, I've had now 4 biscuits, and then it's gone up to 200." They'll be like, I always check my fasting; it has been correct." They didn't realize the effect of the
Exactly.
refined foods and things like that. So
Exactly.
and I wanted to add also, what about GLP-1? Do you think GLP-1,
Yes.
the aspect of helping us to in such cases, do you think it as a behavioral modification tool,
Yes,
can it
definitely.
do not just look at the other benefits, but just purely from appetite control? What do you think
Yes,
GLP-1?
definitely. So that is one of the major benefits which helps us in the Indian population, because once you are on the GLP-1 RAs, your appetite is gone almost completely. So they don't feel hungry, and that is when you have to train yourself to eat less. And eventually, even if you think of stopping the medication, which quite a few of them are used to eating less by then, and so they can sometimes, if not completely, maintain the benefit which they had when they were on the GLP-1 analogs. So I advise them to continue it, but there are a few who want to stop the medication at some point, and in spite of stopping, they don't go back to their original weight, because now they have adapted to the new lifestyle and the new less eating of
Eating
food.
pattern,
Yeah.
yeah.
Yes, yes.
So,
So that
so now
that definitely helps a lot.
So now for the final question. So now
Yes.
we're living in a world where we have the access of data, newer tests. So now in especially in high risk cardiac cases,
Yeah.
um, they don't have. I mean, I'm just painting a picture here. They don't have that much of symptoms, but you know that this particular individual is high risk. So how much of preventive medicine, probably doing a calcium score for this individual, how much of these kind of tests do you think makes a difference? Do you think we should start to use more of these screening tests, or do you think we should, wait and watch? How do you think we should approach it? Knowing that we have all these non-invasive ways of, evaluating these high-risk cases.
Yeah, so definitely there are a lot of new things which are there in the armamentarium which are coming up. Some of them are in the experimental stages, and they are not so widely available. Available in the sense, not so widely used so far for the evaluation of cardiovascular disease. And therefore, the experience is emerging. And I would say that in my practice also, I have not used them so extensively, but definitely you should start using them, at least working them up for, a simple test and evaluating, like C-reactive protein, or a high sensitivity C-reactive protein which has come up, the coronary artery calcium score, and all these things should definitely be offered to these patients to pick up the cardiovascular risk factors earlier and treat them whenever required.
I think, yes, as you rightly put out. So it was great chatting with you, Dr. Manjari,
Yeah,
and have a great day. And so looking forward to discussing more with everyone on these important topics. These dialogues are important, and I think talking about a disease from our perspective makes all the difference. So thank you once again.
thank you